What's up, Ninja Nerds? In this video today, we're going to be talking about parathyroid disorders. This is a part of our clinical medicine section. If you guys like these videos, please support us. You can do that by hitting the like button. You can comment down in the comment section or subscribe. Also, if you guys really want some amazing notes, some great illustrations, I really urge you guys to check out our website. You can do that by going down in the description box below, click on the link, that'll go right to our website. Also on the website, we'll have thousands of questions for you guys to test your knowledge on, as well as we're developing a lot of exam prep courses, such as those of you preparing for the step 1, step 2, PANCE, etc. So please go check those out. All right, let's talk about parathyroid disorders. There's a lot to discuss here. When we talk about the parathyroid gland, it's either a problem where you're not producing enough parathyroid hormone, which we call hypoparathyroidism, or you're producing too much, called hyperparathyroidism. When we talk about hypoparathyroidism, the really problematic issue with this disease is that there's something that's actually destroying the parathyroid glands. So if you guys look in the back of the thyroid gland, you got these little guys right here in blue. Those are the parathyroid glands. They are responsible for making a hormone, which we refer to as PTH. Not too bad, right? So in this disease, hypoparathyroidism, there is a decreased production of PTH. Question arises, why? Why are there a decreased production? Well, one, you could be destroying the actual parathyroid glands, right? There's little cells inside of the parathyroid gland called chief cells. And these pumpies are constantly popping out the PTH, the parathyroid hormone. What if I destroy those for whatever reason? That would definitely lead to a reduction of PTH, correct? So I want you guys to think about destruction. So some type of destructive process of the parathyroid glands. This would 100% though lead to some type of process that leads to the reduction of PTH, right? Another one is it actually could be due to more of a congenital problem. So in patients who maybe have some type of abnormality within their embryological process, such as the development of like the pharyngeal pouches, we'll talk about this a little bit more later, the absence or the lack of functional presence of the parathyroid gland can also lead to hypoparathyroidism. So I want you to think about the absence of the parathyroid gland or destruction of the parathyroid gland as the potential reasons of why you're not making enough PTH. Now, when you don't make enough PTH, this guy works through many different ways. One of them is he works on osteoclasts inside of our bone. And what he helps the osteoclast to do is to reabsorb or resorb calcium from the bone and put it into the bloodstream. But if it's not present, are you going to resorb calcium? No. So if I don't resorb calcium, I'm not going to pull it from the bone and put it into the blood. So what happens to the calcium levels effectively within the blood? They'll drop. So oftentimes these patients can develop what's called hypocalcemia from this effect. The other thing here is that it also works in the kidneys through two mechanisms. One mechanism is it helps to be able to try to reabsorb calcium across the distal convoluted tubule. But if you don't have PTH present, can you reabsorb the calcium? No. And so because of that, you can't reabsorb calcium into the bloodstream. This leads to hypocalcemia. The other problematic issue here is that the PTH also acts on the proximal convoluted tubular cells and triggers these kidneys to activate vitamin D. So it helps them in converting 25-hydroxycholecalciferol into 1,25-hydroxycholecalciferol. Now, if we have less active vitamin D, so we have less of what we call active vitamin D, which is also known as 1,25-dihydroxycholecalciferol, what happens? Well, then you don't absorb calcium across the GIT. And if you don't absorb calcium across the GIT into the bloodstream, what happens to the calcium levels in the blood? They go down. So oftentimes in patients with hypoparathyroidism, they may have hypocalcemia. The other effect that you may want to add into your repertoire to remember this is that parathyroid also is supposed to excrete phosphates from the kidneys. And so if you don't have that, are you going to be able to excrete phosphates? No. And so just add this into your memory as well, is that there may also be high levels of phosphate inside of the bloodstream as well in patients with hypoparathyroidism. So add this as a plus or minus to help you guys to remember. That's hypoparathyroidism. Now, son of a gun. The next concept is we have to talk about what's leading to the destruction of these parathyroid glands and what's leading to the absence of the parathyroid glands. Well, the first thing is, when we talk about parathyroid gland destruction, there's really only two pertinent causes for your exams. One is you cut the parathyroid glands out. And it wasn't maybe purposeful, or maybe it was purposeful. So we determine this is based upon the need for a surgical procedure. So sometimes patients go in and they get these things called thyroidectomies. Maybe they have hyperthyroidism, maybe they have some type of thyroid nodule or cancer, and they need to get part of their thyroid or all of their thyroid removed. When you do that, you have to be very careful not to remove the parathyroid glands. But sometimes, incidentally, during a thyroidectomy, they may accidentally remove part of the parathyroid gland. So I want you guys to remember that patients who receive something called a thyroidectomy may lead to an undesirable or inadvertent removal of the parathyroid glands. Yes. Okay, what else? Well, another mechanism is that you're purposefully trying to remove the parathyroid glands. What's that procedure called? That's called a parathyroidectomy. So if a patient is getting a parathyroidectomy, maybe because they have hyperparathyroidism, or because they have something else wrong, maybe they have like a parathyroid tumor of some sort, that also, my friends, can lead to this process where you remove the source of the parathyroid hormone, such as the parathyroid gland. So what I want you to think about is, has the patient had any thyroid surgery or parathyroid surgery? Now, what are some hints to remember this? Look for surgical scars. Look for a history of recent neck surgery. So if they have surgical scars here, or they've had a recent surgery around their neck region, this could definitely be the source of their hypoparathyroidism. Okay, next one is autoimmune. Now autoimmune, this one's a little bit different. There's autoantibodies that are attacking the parathyroid gland. Now, these autoantibodies that we see here, there are so many. Usually it would be so beautiful, it really would be, if we had specific types of autoantibodies that are really pertinent to this process. But we don't. What we do know is, in a disease called autoimmune polyglandular syndrome type 1. So I'm going to write this down here. It's going to be called APS, autoimmune polyglandular syndrome type 1. This is an autoimmune disease that attacks the parathyroid glands. There's these autoantibodies that are really the source of these problems here, and they're damaging the parathyroid glands. If you damage these, can you produce PTH? No. So you see how that affects this. Question is what's leading to the autoantibody production? There's a gene that's suspected that triggers this process. It's called the AIR gene. So if they have a mutation in the AIR gene, this mutation may then stimulate autoantibody production. If you cause these autoantibodies to be produced, they will then lead to destruction of the parathyroid gland. And then as a result, no production of PTH. Same thing in this situation. If you destroy these, can you make PTH? No. In this one, if you destroy them, can you make PTH? No. And so as a result, in both of these, there is a reduction in PTH. The question arises with this one, I know that it's some type of surgical history. In this one, it's not really a surgical history. It's weird. With this one, what you're really looking for is something called a triad. So with APS1, they usually present with a triad of features. What is this triad? Well, one of them is they can present with what's called mucocutaneous candidiasis. And it is usually very chronic. So they'll end up with lots of nasty thrush within the mouth and around the actual lip region. The other thing is they can also develop adrenal failure. So if a patient can actually develop Addison's disease or acute adrenal insufficiency, and this is really dangerous. So if a patient presents with adrenal insufficiency and mucocutaneous candidiasis, and then lastly, they also present with hypoparathyroidism, you really want to start thinking, could this be APS1? So the triad of mucocutaneous candidiasis, adrenal failure, and hypoparathyroidism should make you start to suspect that this patient could have a autoimmune component. Now you would think, well, Zach, when I get to the diagnostics, how do I know the autoantibodies? I know. You're not really looking for that. You're looking more for the clinical context in the situation and the lack of surgical history to really let you think that it's autoimmune rather than iatrogenic. Okay, with that being said, we know that these are leading to a reduction of PTH. What else could it be? Well, we said it could be the absence of the parathyroid gland. There's a disease, it's more of a congenital. We'll probably talk about this a little bit more in the pediatric section, but we're going to breeze through it relatively quickly. DiGeorge syndrome is a process where there is the lack thereof of the formation of these pharyngeal pouches. So you have these pharyngeal pouches, they're called the third and fourth pharyngeal pouch. And these things help to make a bunch of different structures. But what happens is these things don't form correctly. So whenever you don't have the proper formation of the third and fourth pharyngeal pouch, what this leads to is the absence of the parathyroid gland, along with other structures. So this process here is the third and fourth pharyngeal pouch doesn't form. So there's a process here where it doesn't actually occur. So third and fourth pharyngeal pouch don't form. Now, what does that lead to? It leads to the absence of the parathyroid glands. Now, if you don't have these, can you produce any PTH as a result of this? No. And so as a result, this is usually going to cause more of a pediatric type of presentation of hypoparathyroidism. How does that usually present? Because that's helpful. Usually this will present what we call the catch-22 features. And so this is how you remember it. You remember C for cardiac defects. They have many different types of cardiac defects that are usually congenital. The other thing that they can also have with this particular disorder, which is kind of interesting, is they have a lot of facial abnormalities. And we call this an anomalous face. They also, and this is the really, really big one, the third and fourth pharyngeal pouch not only help with cardiac outlet formation, they also help with facial formation and a gland that kind of forms right on top of the heart called the thymus gland, which is really important for immune system development, especially for the T cells. So the thymus gland actually doesn't get formed properly. And so they can experience what's called thymus hypoplasia, which puts them at super high risk for infections, all right? The other one here is they can also have cleft palates, which is also really important to remember. So the cleft palate. And last but not least, they have hypoparathyroidism. So these are going to be the big things that I want you guys to be able to remember. Now, with this being said, the question comes about here, what is actually going to be the particular trigger for this process? Why does the third and fourth pharyngeal pouch don't form? The reason why is you have a deletion in chromosome 22. So there's a specific portion here called chromosome 22. So there is a chromosome, let's actually use this here, since that red's starting to kind of go dry, that chromosome 22 deletion. That chromosome 22 deletion is what triggers the third and the fourth pharyngeal pouch to not properly form, which leads to hypoparathyroidism as well as the other components of the catch-22 mnemonic. All right, so please don't forget, here, let's see if we can kind of get this in there, 22. To remember that DiGeorge syndrome is more of a congenital type of hypoparathyroidism that usually is a result of absent parathyroid along with thymus gland formation, as well as cardiac defects, facial abnormalities, and a cleft palate, usually due to chromosome 22 deletion. All right, beautiful. Well, that covers hypoparathyroidism. The question then is, what about hyperparathyroidism? Well, with hyperparathyroidism, the problem is that you're producing way too much of that PTH, all right? So there's a way too much of an inappropriate production of PTH. Now the question arises here, what's causing these parathyroid glands to pump out too much PTH? Why is this happening? Well, there's many different reasons why, but oftentimes the most simplest answer is that these chief cells, which are the cells that make up most of the parathyroid gland, the secretory portion of the parathyroid gland, they're hyperfunctioning. And so the primary etiology for this is usually a hyperfunctioning parathyroid. With that being said, if this puppy is super hyperfunctioning, so in other words, you're gaining the capacity for these cells to either undergo replication or become cancerous. Maybe they become like an adenoma. They gain the capacity to produce PTH inappropriately. PTH will then go to the bones, and when it goes to the bones, it'll super activate the osteoclast. If it activates the osteoclast, it's going to cause massive bone resorption, which will leach calcium from the bone and put the calcium into the bloodstream. And for the most part, this will lead to elevated calcium levels in the blood. The other thing that it'll also do is it'll act on the kidneys. It'll cause increased reabsorption of calcium in the distal convoluted tubule, which will cause high calcium levels within the bloodstream. The other thing is that PTH will also activate the enzyme that helps to hydroxylate vitamin D into the active form. So you'll end up with an increase in active vitamin D. And if I have an increase in active vitamin D, what's going to happen? I'm going to absorb lots of calcium across the gut into the bloodstream. And this is going to increase my calcium levels. Hypercalcemia tends to be the most common feature in patients with hyperparathyroidism. We'll talk about a small caveat in one of those types, but for the most part, it's hypercalcemia. The other thing is phosphate. Now, PTH is supposed to help take and reabsorb calcium and excrete phosphate in the kidneys. Sometimes with this being said, if the PTH is really high and it's because of a primary or sometimes in this particular case, it may dump out phosphate. But here's the thing, I'm not going to write down that it's actually going to be low. You would say, oh, well, if it's hyperparathyroidism, it would dump phosphates. And so it would be definitely high calcium, low phosphates. That's not necessarily true. In this one, it could be high or it could be low levels of phosphates. And we'll talk about that caveat a little bit later because it depends upon the type of hyperparathyroidism. Okay, we now know that a hyperfunctioning parathyroid is the source for this. It's the primary pathophysiological process. What's the causes of this pathophysiological process? Well, there's 3 types of hyperparathyroidism. Primary, secondary, tertiary. Not too bad, right? Primary is by far going to be one of the most common causes. Usually what this means is that the parathyroid gland itself is the problem. There's nothing else that's causing this problem. It's the parathyroid itself. And there's usually 2 big problems. One is there is a adenoma. And adenomas are going to be by far the most common cause. All right, they account for maybe approximately 80%, if not maybe even a little bit more, of primary hyperparathyroidism. Okay, so that's by far going to be the case where you have this tumor, let's say tumor that gains the capacity to secrete large amounts of PTH. So this tumor gains the capacity to produce large amounts of PTH on its own. So it gains autonomous production. Right? That would be a very, very prominent reason. What's another one? This one they like to get you for the exam, okay? They like to get you because anytime they can add a name onto this, it really, really helps. But there's this other diseases called multiple endocrine neoplasia, right? So there's multiple endocrine neoplasia type 1, and there is multiple endocrine neoplasia 2A. Now, when you have these particular disorders, these are disorders where they cause neoplasia of the parathyroid gland, but other endocrine tissues. So these will cause hyperplasia. They'll cause increased replication of the parathyroid tissue. So it'll trigger what's called hyperplasia of the parathyroid tissue. The hyperplastic tissue will then gain the capacity to produce larger amounts of PTH, which will then go and affect its target organs. What really helps us with this one is we know that this is by far the most common cause. But with multiple endocrine neoplasia, this is helpful for the vignettes. For one, I want you to remember the 3 P's for this one. All right? So for men 1, I want you to remember the 3 P's. P, P, P. For this one, it goes, it's a pituitary tumor. So this is pituitary adenomas. This is a pancreatic tumor, which we call a gastrinoma. And then last one is it's going to be a parathyroid problem, usually parathyroid hyperplasia. So with men 1, I want you to remember the 3 P's. A patient will have hyperparathyroidism, pancreatic tumors, and pituitary adenomas. With men 2A, I want you to remember 1 M and 2 P's. 1 M and 2 P's. This may be super stupid, but it helps me. I remember that A is like the first letter in the alphabet, and so I remember 1 M is going to be that helpful point. Whereas in men 2B, which is another type, you'll have 2 M's and 1 P. It's simple, kind of helpful way for me to remember it. But I remember 1 M and 2 P's for this one. So for men 2A, they'll also have parathyroid hyperplasia. Same thing, where the parathyroid tissue is super hyperplastic and gains the capacity to produce large amounts of PTH. But they also have two other tumors. One is called a pheochromocytoma. This is a tumor of the adrenal medulla that pumps out large amounts of epinephrine, norepinephrine. And medullary thyroid cancer. Now, with that being said, if I can help myself to remember that if they have multiple types of endocrine abnormalities with the presence of hyperparathyroidism, I should definitely be thinking of MEN1 or MEN2. Helping me know these a little bit more in detail will help me determine if it's MEN1 or MEN2A. Adenoma by far, though, please remember, it's likely going to be the most common cause. This will account for maybe 20%. Now, with that being said, with primary hyperparathyroidism, I remember I told you that it can be up or down, so you can have either high or low phosphates. Let's explain this. With primary hyperparathyroidism, the kidney is okay. I'm going to put a check mark. It's good. It's working. It's functional. So what happens is PTH will go to the bones, it'll go to the kidneys, and it'll help to activate vitamin D. All that stuff will happen, right? The same way that we described below, over here. And that in this process, what we will lead to is if the kidneys are intact, right, we know that you will help to reabsorb calcium, resorb calcium, and then absorb calcium. All of this stuff, as long as the kidneys are intact, all of this should happen, and you should increase the calcium. Another thing is, if the kidneys are also intact, whenever PTH is present, it is dumping phosphate. Whenever you reabsorb calcium, you dump phosphate. So if I dump phosphate, what should happen to my phosphate levels? They should plummet. And so in this patient, they will have high calcium and low phosphate. That is really important. I really need you guys to remember that. For primary, it's always high calcium, low phosphate, normal renal function. All right? Likely some type of mass or process in the parathyroid that's causing this problem. Secondary is interesting because it's not a problem with the parathyroid originally. Something triggered this thing to go haywire. What is that thing? Usually it's something that triggered the parathyroid gland to say, oh, I'm going to start kind of replicating myself and producing more PTH. So I'm going to start producing more PTH, way more than normal. But it's not because I have an adenoma or hyperplasia. What happens is I either have something wrong with my kidneys, so they're damaged in some way, or I have very low vitamin D. So a vitamin D deficiency, or what we call chronic kidney disease. What happens is vitamin D is supposed to do what at the GIT? Absorb calcium. So it helps to absorb calcium. But the other thing that's really cool about this is that vitamin D not only will it help to absorb calcium, which will lead to what? If you have low vitamin D, you won't absorb calcium, so you end up with what's called hypocalcemia. And hypocalcemia is interesting because there's these little receptors on the chief cells in the parathyroid gland that actually are sensitive to calcium. So whenever calcium levels are low, they're like, oh shoot, oh, better amp the activity up and start pumping out PTH. And so that's usually what the trigger is it'll tell the parathyroid gland, hey baby, start pumping out some PTH. And that's a very profound stimulus. Now vitamin D itself, if it's low, can also directly do this, but follow my train of thought here. If a patient has a low vitamin D, low calcium, triggers the PTH to go up, why? Because PTH will then act on the bones, the kidneys, and the GIT to all increase the calcium, right? Well, here's another thing. With CKD does two things. One is that we already know that it's supposed to filter things out. And what it's supposed to filter is phosphorus. And so what happens in patients who have really bad CKD, their phosphorus levels start going up. Now, when the phosphorus levels go up, you know what phosphate does to calcium? It binds to it. And when it binds to calcium, guess what it does? It makes less of the free or ionized form of calcium present. So now what I'm going to do is I'm going to take the phosphates, and this high phosphate is going to lead to lower amounts of free calcium. Let's write that above it. Less free calcium. And that's going to stimulate the parathyroid to start producing PTH. The other thing is that the kidneys are also responsible for activating vitamin D. Well, if I can't have good kidneys, am I going to activate vitamin D? No. And so as a result, if the kidneys are stinking at their job, will they lead to adequate vitamin D production? No. And so if they don't, that leads to less vitamin D, less calcium that's free, and more hitting on that parathyroid gland to say, hey buddy, I need more PTH to increase the calcium levels. That's the concept here that's really interesting. So the big thing that you really want to remember here is in CKD, we define that based upon what? A GFR. So the lower the patient's GFR, the more likely that they are going to have a lower active vitamin D and higher amounts of phosphates, which are dropping the calcium and causing increased PTH. With that being said, PTH will work on the bones. It'll go to the kidneys. It'll try to play a role within the vitamin D activation. But here's where I want you to follow along with me. If this is secondary hyperparathyroidism, it'll try to act on the bones and say, hey, osteoclast, try to chew up the bone and release calcium into the blood. So it'll do its best to do that. The kidneys are jacked up though in CKD, right? So if the kidneys are kind of jacked up in CKD, what do you think would happen? Are they going to be able to really reabsorb calcium very well? Probably not. Are they going to be able to excrete phosphates very well? Probably not. But one of the things I do know is that it's just not going to do a very good job in comparison to this normal kidney here at being able to reabsorb calcium. The other thing is, if I don't have vitamin D or I have CKD that's not leading to active vitamin D, what am I experiencing here? I'm having less vitamin D. If I have less vitamin D, am I going to absorb as much calcium? No. So the problem that you kind of run into here is that if a patient has CKD, you're not going to absorb as much calcium and you're not going to make as much vitamin D. If you have vitamin D deficiency, you're not going to have as much vitamin D and you're not going to absorb as much calcium. So the only thing that's really working here is the bones. But the bones by themselves are not going to be able to reabsorb enough calcium to increase the calcium levels. And so oftentimes in these patients, they have low or normal calcium levels. Here's what's really interesting though. In CKD, what do you notice about the phosphate levels? They're very high. Vitamin D, the phosphate levels should be relatively normal. So that's another thing that's really helpful. And when we talk about this more in the diagnostics, is CKD would have lower normal calcium and high phosphates. Vitamin D deficiency would have low or normal calcium, but it would have normal phosphate levels. It will also have a normal GFR. This will have a poor GFR. So there's certain things that'll help you guys in differentiating these two. But that's the interesting part here, is that the calcium levels could be low or normal, but the phosphate is high in CKD and it could be normal in vitamin D. So you see why I told you over here, it could be high or low. Here's where you come into a very weird concept I just want you guys to truly be able to understand here. This last one we see really only in CKD. All right, you really see this too often in vitamin D deficiency. What happens is, in this patient who has CKD, but it has really progressed. Let's say it's progressed beyond to the point where the patient is almost to the point where it really requires hemodialysis. So whenever they're requiring hemodialysis or at that point, they're at end-stage renal disease, right? They're at the point where their GFR is so low that they're uremic or they are needing or on hemodialysis. At that point, what we see here is something very interesting. We already know the mechanisms. It's going to cause hyperphosphatemia and it's going to cause less active vitamin D. I don't need to highlight that. But what it will do is it'll tell these parathyroid glands start replicating, and replicating. Eventually, these parathyroid glands will become self-sufficient because they're going to be so used to this stimulus from end-stage renal disease that it will pump out insanely high levels of PTH. Insanely high levels of PTH. So it gains massively autonomous production, similar to primary. And then what it does is it goes to the bones, it goes to the kidneys, it tries to play a role within the vitamin D process. But when that PTH is so crazy high, what will happen is that these patients will, believe it or not, work through a massive bone resorptive process to where they will be able to increase their calcium levels. And their phosphate levels will also be really high. And so you kind of notice a trend here with the primary, secondary, and tertiary processes. This process is going to be where the PTH levels are so high because end-stage renal disease is causing chronic hyperphosphatemia, Chronically low vitamin D levels, which are stimulating the parathyroid glands to replicate, become autonomous, and produce massive PTH levels. PTH will then cause massive bone resorption, enough of the calcium reabsorption, enough of the activation of vitamin D to reabsorb a ton of calcium, but because the kidneys are damaged, they will not be able to excrete the phosphates, and the phosphates will remain high. So what you can notice here, which is really interesting, is tertiary, high calcium, high phosphate. That's really important, crazy high PTH, and massively low GFR. Secondary is normal or low calcium, high phosphate, low GFR. Vitamin D deficiency, low vitamin D, lower normal calcium. But both of them will have a high PTH. Primary, high PTH, high calcium, low phosphate. So you start noticing the difference between these guys. All right, okay. At this point, we've talked about the parathyroid disorders with respect to pathophysiology and causes. Now what I want to do is talk about what is the downstream consequences of hypocalcemia and hypercalcemia. All right, my friends, so we're now going to move on to the next part, which is what is the problem with parathyroid disorders? So we talked about whenever it's too low, hypoparathyroidism. We talked about when it's too high, hyperparathyroidism. We talked a lot about the pathophysiology behind it, a lot of the causes. We'll kind of recap those quickly throughout this process, but I want you guys to think about what's the actual downstream issue with having hypo or hyperparathyroidism. And really it comes down to derangements in calcium is really what it comes down to. So in patients who have hypoparathyroidism, what we know is that they are not producing an adequate amount of PTH. Just to recap that, what could it be due to? Parathyroid destruction. Iatrogenic causes, think about surgical history, right? Especially around the neck region, thyroid parathyroidectomy, or autoimmune. Think about the AIR gene mutation that leads to the triad of autoimmune polyglandular syndrome type 1, which would be chronic mucocutaneous candidiasis, adrenal insufficiency, and hypoparathyroidism. And then lastly, also think about that. What is syndrome? DiGeorge syndrome, the chromosome 22 mutation that leads to absence of third, fourth pharyngeal pouch, so they get the catch 22 features. Now, if you produce an inadequate amount of PTH, that means less osteoclastic activity, less resorption of the bone, leading to less calcium being liberated into the bloodstream. So right now we know that they'll have less calcium in the bloodstream because of that very reason there. The other concept here is that you'll also have less reabsorption of calcium across the distal convoluted tubule. You'll have less active vitamin, what? D, right? So you have less of the active vitamin D. That means you'll have less absorption of calcium across the GIT. So what we end up seeing with this patient population is that they'll have a low calcium. What else could they also have? They also could have a high phosphate. So they can have hypocalcemia, and they may also have hyperphosphatemia. Why would they have hyperphosphatemia? Remember, PTH is the parathyroid hormone, but I also like to think about it as the phosphate trashing hormone. It likes to excrete phosphate. If you can't have if you don't have parathyroid present, can you trash the phosphate in the urine? No. So it builds up in the bloodstream. So this is the combination of effects that we get here. Now, why is hypocalcemia and hyperphosphatemia bad? Well, particularly the calcium is the problematic issue here. What happens is that whenever you have low amounts of calcium, calcium is really interesting. Pretend I represent calcium as like little black dots. Whenever you have these like little black dots, what they do is they surround sodium channels in the neurons inside of our brain and within the spinal cord. And so whenever you have very little amounts of calcium present, these sodium channels are not really impeded. So these sodium channels are really kind of nice and open. And that allows for sodium to easily and quickly influx into these neurons. So it really increases sodium ion influx. If I increase the sodium ion influx, what do? I bring more positive ions into this cell. When I bring more positive ions into the cell, I increase depolarization of these neurons. So now, as a result, I'm going to have increasing depolarizing waves coming down these neurons. I'm going to have an increase in neurotransmitter release. So what I see out of this is an increase in what we call action potentials and an increase in neurotransmitters. The end result here is that if I'm releasing lots of neurotransmitters, I'm stimulating these nerves, I'm stimulating muscles, what these patients oftentimes experience is what's called neuromuscular excitability. Oftentimes we refer to this as tetany. Now, tetany can actually look a couple different ways. What are the ways that this can really look? Well, one is it may cause some of the nerves around the lips to really become interesting in the sense that they kind of have what's called paresthesias. So they may have what's called perioral paresthesias. The other concept here is that it also may really affect the sensitivity of the facial nerve. And so sometimes what happens is you can test it. It's actually really cool. You take and you tap over where the facial nerve would run, and it causes an increased excitability of the facial nerve. It causes contraction of the muscles from the facial nerve being stimulated. And this is an interesting sign. I'm going to show you guys a picture of it in a second, but it's referred to as Chauvet sign. And this is what it looks like here in just a second. The other concept here is that it really can cause increased excitability of some of the nerves, particularly like maybe the median nerve. So sometimes what happens is you inflate a blood pressure cuff. When you inflate the blood pressure cuff, you may activate some of the nerves and some of the muscles. And what it can do is it can cause, you'll inflate the blood pressure cuff and you'll start seeing their muscles on the actual forearm start flex and their wrists start flexing. And this is very interesting. And this is usually referred to as Trousseau's sign. And this is what it looks like right here. If I have a patient who presents with tetany or neuromuscular irritability findings, I'm really thinking about hypocalcemia and maybe even some degree hyperphosphatemia. In rare situations, it may even cause patients to have potentially seizure activity, but it's usually they have to have some underlying neurological disorder that kind of tips them over the edge. The other concept here is that these ions may also have a very profound effect on the cardiovascular tissue. They may trigger some of the actual cells inside of the heart, the myocardial cells, to become agitated, irritated. And what it may do is, I want you guys to remember, there's what's called the QT interval. And so patients who have really profound hypocalcemia are very prone to arrhythmias. And here's the arrhythmia that I want you guys to remember. You can remember this as an inverse relationship. So with low calcium comes a prolonged or increased QT interval. So I want you to remember as the inverse relationship here. With a prolonged QT interval, what happens is you increase the risk of a very dangerous arrhythmia when it happens in an R-on-T phenomenon. And this dangerous arrhythmia that can occur is called torsades de pointes. The problem with torsades de pointes is this can quickly break down into ventricular fibrillation, and it can cause sudden cardiac death. And so the big things that I want you guys to remember is hypocalcemia, profound hypocalcemia may cause tetany or neuromuscular irritability, as well as arrhythmias, such as prolonged QT interval. Okay, we've talked about this concept with hypoparathyroidism. What about hyperparathyroidism? Well, for the most part, what we've discerned from talking about in the last lecture is that we know that these patients are producing a very profoundly large amount of PTH. Could be primary, like a adenoma. Could be multiple endocrine neoplasia 1 or 2A. Usually remember those triads, the 3 Ps or the 1M and 2 Ps. It also could be due to secondary hyperparathyroidism like vitamin D deficiency, CKD, or it could be due to tertiary hyperparathyroidism, which is end-stage renal disease, where the secondary hyperparathyroidism has led to those parathyroid follicle cells, parathyroid cells, becoming hyperplastic and autonomous in their ability to produce PTH. Now, in primary, I'm just going to write this down because I don't want you to forget this. In primary and in tertiary hyperparathyroidism, you will see profound levels of calcium. Because what will happen is this high PTH will stimulate the osteoclast and really cause increased resorption of calcium. You may also have problems with the kidney, where they also will reabsorb lots of calcium. And you may reabsorb a lot of calcium across the kidneys. You may also lead to increased activation of vitamin D. So if you have increased vitamin D, this may also increase the absorption of calcium across the GIT. So the end result here is you may have an increase in calcium in patients who have primary and tertiary hyperparathyroidism. You may not see this, and usually will not see this, in secondary hyperparathyroidism. But that doesn't mean that PTH isn't elevated in that disease. The other concept is that you can see fluctuating levels of phosphate. For example, if it is primary versus if it is tertiary. So if I were to combine this two, if I had primary, this is usually going to be a low phosphate. And if it's tertiary, they will have a high phosphate. But either way, the big thing that I really want you guys to remember here is that calcium is really the big problematic issue here. Calcium be way too dang high, all right? Now, what's the problem with calcium? There's a mnemonic that we often use in medicine called stones, bones, groans, thrones, and psychiatric overtones. And what it helps us to do is organize our thoughts in a way to remember the most common effects of hypercalcemia. What are some of those effects? Well, one is it can affect the kidneys. So this goes along with the concept of stones. What happens is whenever you have high levels of calcium, that calcium gets excreted across the glomerulus and combines with oxalate. And so these patients often have an increased risk of what's called calcium oxalate stones, which puts them at high risk for, what do we call this? When you have lots of calcium oxalate stones, it increases the risk of what we refer to as nephrolithiasis. So that's one thing, is kidney stones. Stones, bones, groans, thrones, psychiatric overtones. That's one thing that these patients are really high risk of, all right? It's causing a stone that's obstructing the flow of urine, which may lead to hydronephrosis, increased risk of urinary tract infections, hematuria, etc. The other concept here is that these patients have problems with the bones. Remember I told you that PTH is causing massive resorption of calcium from the bones. You're just leaching calcium and other molecules from the bone, and it's going to cause the bone to become weaker, less dense. And what happens is this increases the risk of, I'd say, predetermined in some way, or acceleration of bone destruction, which can lead to diseases called osteopenia or osteoporosis. The problem with this is that if you increase the rate of osteopenia and osteoporosis, you increase the risk of pathological fractures. And so this is one of the big things that can happen here, is that there's increased risk of fractures that can occur. And this is where you get the bone pain. Osteopenia and osteoporosis don't cause bone pain in itself, but they do increase the risk of pathological fractures. Oftentimes you need a DEXA scan to really determine if you have these two disorders, but a fracture may be identified off of X-ray. Okay, the other concept here is that it also leads to pancreatitis. Right? What happens is when calcium is in really high levels, it increases the activation of proteolytic enzymes. So it activates pancreatic enzymes. And when you activate these pancreatic enzymes, one of the problems is this leads to the inflammation and digestion, and then subsequently inflammation of the pancreas. And so this leads to what we refer to as pancreatitis. Now, with pancreatitis, you will have severe abdominal pain, all right? So we say stones, bones, groans. It's abdominal groans because this causes classic epigastric abdominal pain. And then also that lipase is usually 3 times the upper limit of normal. So that's another feature. The next one is really interesting. So what happens is these patients, whenever you have super high calcium levels, there's a hormone that our body makes. It's called ADH, also known as vasopressin. ADH likes to bind onto these receptors here called the V2 receptors. And what it's supposed to do is as water moves through the collecting duct, so it will move through this collecting duct, it wants to get absorbed. So some of this water should be absorbed. Some of it will go into the urine, right? Now, ADH plays a big role in stimulating this reabsorption of water into the bloodstream. But whenever people have high calcium levels, this high calcium level will inhibit the effect that ADH has on these receptors, and it will in fact inhibit this process. And I won't be able to absorb water into the bloodstream. So I get decreased water reabsorption. And as a result, I end up with a lot of water loss in the urine. And so what ends up happening is a twofold process here. When you lose a lot of water into the urine, what do we call that whenever it's really large volumes, very frequent urination? This is called polyuria. The other thing is when there's less water reabsorption, this causes the osmolality of the actual blood to become much higher, which then tells your hypothalamic thirst center, oh man, I got to really start drinking more water to reaccumulate more water in the bloodstream. What's that called when you drink tons and tons and tons of water very frequently? It's called polydipsia. It's called polydipsia. And so this will usually stimulate this process. So if a patient has polyuria, polydipsia, and maybe also in combination with this profound dehydration, so usually it's a combo, it's polydipsia, polyuria, and because of water loss in the urine, dehydration, then what you really want to think about here is a patient having a very interesting condition called nephrogenic diabetes insipidus, DI. So remember I said stones, bones, groans, thrones. You're peeing all the time. You're on the throne peeing all the time because you're having massive polyuria, you're thirsty as a result, and you're becoming dehydrated from all that volume loss. This is really, really important. The last one is I like to remember an add-on. So remember I said stones, bones, groans, thrones, psychiatric overtones. That's usually these patients are usually a little bit more agitated, irritated, delirious. But I also like to add on one more. They're arrhythmia prone. So remember I told you that the QT interval is inversely proportional to the calcium level? And what I mean by that is that what we see here is that you are also at increased risk of arrhythmias. So they are what's called, we'll put this just to add to the kind of mnemonic, arrhythmia prone. I told you that if the calcium levels are high, the QT interval should be lower. And so as a result, what I would want to see is a decreased QT interval. The problem with a decreased QT interval is it puts the patient at more of a risk for bradycardia, so heart blocks and things of that such. So it makes them more at risk for bradycardia. But I just want you to remember the relationship between the QT interval and the calcium. At this point, we've then surmised the complication that you can see in hyperparathyroidism as a result of hypercalcemia. And we surmised the complications that you can see in hypoparathyroidism secondary to hypocalcemia. Now we're going to move into the meat and potatoes of this lecture, which is the diagnostics. You've gone through a lot about the parathyroid. How do you get to the bottom of it and determine if the patient has hypoparathyroidism and determine if it's like really, is this a primary problem or not? Well, and a patient who has hypoparathyroidism, oftentimes it's almost always usually primary in some way, shape, or form. You just have to figure out a little bit more about, is it autoimmune? Is it a recent surgery? Or is it potentially a congenital problem? So how do I do that? Well, oftentimes hypoparathyroidism should also correlate with hypocalcemia, right? The other thing is that parathyroid is supposed to excrete phosphate, but if you're not excreting phosphate because you don't have enough PTH, it should be up. So low calcium, high phosphate should suggest a parathyroid problem. So then I got to go ahead and check, do I have a PTH problem? Obtain it. If the PTH is low, that's the reason why this is happening. And then you have to kind of come to the point here is, was it iatrogenic? Was it autoimmune? Was it congenital? So I think that maybe I'll go ahead and look at their history. Did they get a recent neck surgery and they had a thyroidectomy, a parathyroidectomy? They had a radical neck dissection? Oh yeah? It's probably that. It's probably iatrogenic related. If it's not, then I got to think, okay, it could be autoimmune or it could be congenital. Get genetic testing. Oftentimes we test a gene, it's called the AIR gene. And if they have the AIR gene mutation, and on top of that, they have the chronic mucocutaneous candidiasis, adrenal insufficiency in combo with hypoparathyroidism, it's probably autoimmune polyglandular syndrome type 1. The other one is check the, for the catch-22 features. Do they have the 22 gene mutation and the catch findings? If they do, it's probably DiGeorge syndrome. The other thing that you could do is you also could obtain a magnesium level and see if that's deficient and then replete the magnesium and see if they improve their PTH levels. This one's weird. We didn't talk about this, but what if their PTH levels are high? All right, Zach, this doesn't make no sense. How can you have low calcium, high phosphorus, and high PTH? Right away, you might be thinking, oh, is this that secondary hyper? Yeah, parathyroid? No, it's not. And these patients, they have a very mild, very, very transient, very, very low level of PTH elevation. It's nothing significant, just very mild elevation. Not super high that I'd be concerned that they have secondary hyperparathyroidism. It's just a little bit elevated. And in this patient, it's probably because they have something called pseudo hypoparathyroidism, meaning the problem is due to the PTH receptor. They have a problem where the PTH is binding to the PTH receptor, and the PTH receptor is not exhibiting the response to try to increase the calcium or excrete the phosphate. So because of that, it's like the PTH is just not even present in a way, because again, the receptor is not responding. So they'll still have hypocalcemia, hyperphosphatemia, which will then tell the parathyroid, hey, make more PTH, because my calcium levels are still low, my phosphorus levels are still high. But the PTH receptor will not respond, and that's pseudo hypoparathyroidism. All right, cool. We come to hyperparathyroidism now. So again, high PTH, for the most part, the calcium should be, again, high, and the phosphate level can vary a little bit, right? So let's think about this. If the calcium is high and the phosphorus is low, okay, that means PTH is being produced, it's reabsorbing calcium, so it's either primary or tertiary, one of the two. Those are the only ones that I know that can definitely have high calcium. Phosphorus low. And that means that PTH is actually working on a kidney that's functional, that's excreting the phosphate, so it can't be tertiary. This has got to be primary then, right? So usually this would be primary. In a rare scenario, it could be tertiary, but it's unlikely. So let's kind of evaluate this a little bit more. I think it's one of the two. What I'll do is I'll get a PTH level, I'll get a vitamin D level, and I'll get a BMP. If I get this and the PTH is really high and the GFR is super low and their phosphate's high, it's tertiary. Done. It's probably CKD related. That's the reason why. Now, from here, what you should do is remember, in patients who have very bad hyperparathyroidism, you're going to chew away at the bone and you're at very high risk for kidney stones. So oftentimes it's very beneficial to kind of stratify the risk of this patient by getting a DEXA scan, looking, hey, do they have any osteopenia, osteoporosis, risk of pathological fractures? That's helpful. And then get a renal ultrasound. Do they have any like frequent episodes of nephrolithiasis? There's their hypercalciuria that maybe concerns me with these patients, because that's going to help you to determine their level of treatment. The next thing is if I get the PTH and it's high, but the GFR is normal, it can't be tertiary. It just can't. Plus, if the phosphate's low, it's definitely primary. So I think it's primary, but I'm going to add a little kind of caveat here. There's another disorder called familial hypocalciuric hypercalcemia. The difference between these is thus within the name, familial hypocalciuric. That means they have low calcium in their urine. And patients who have primary hyperparathyroidism, their calcium is going to be so high that it's getting filtered across their kidneys, Zach said, and it's forming calcium oxalate and calcium phosphate stones. So that can't be the case if it's primary hyperparathyroidism. Their urine calcium has to be high, and this one will be low. Get a urine calcium. If the urine calcium is low, it's FHH. And if the urine calcium is high, it's primary hyperparathyroidism. And then again, in any primary or tertiary hyperthyroid state, you should get a DEXA scan, look to see if there's any like true bone disease, and then get a renal ultrasound. Look to see if the kidneys are really getting damaged, if they have a lot of nephrolithiasis or hypercalciuria. Okay? One more thing. In tertiary, we know the cause. It's the kidney damage. All right? I can identify that based on the GFR. For primary, we don't know if it's an adenoma, if it's hyperplasia, or what. So what I think is the best thing to do is oftentimes it's most commonly an adenoma. Get a thyroid ultrasound. Sometimes you may be able to see that there's an adenoma there present in the parathyroid gland, but oftentimes one of the best tests is a sestamibi scan. You give them some type of like tracer, and what happens is if there is a parathyroid adenoma, these things will light up. They'll become very, very dark. All right. And so that's what you'll be able to see is after you give them this, look, it's still remaining around after 2 hours. So this is definitely indicative of a parathyroid adenoma. These are very, very helpful for parathyroid adenoma. CT scan can also be an alternative, but usually between these, a sestamibi scan would be one of the most, best tests to be able to identify a parathyroid adenoma. All right. Calcium's low, or maybe even normal, and the phosphorus is high. Oh, baby, that's secondary. That's secondary hyperparathyroidism all day, right? I just got to know, is it due to CKD or is it due to vitamin D deficiency? Get a PTH, right? Get a vitamin D and a BMP. If the PTH is high, all right, cool, it's secondary hyperparathyroidism. But the next thing I want to do here is I need to check the GFR, all right? If the GFR is low, oh, that's CKD. And what else would be happening here? The phosphate would be super high. That's CKD, I'm done. If it's high phosphate, low GFR, high PTH, and low or normal calcium, it's CKD-related secondary hyperparathyroidism. Done. The other thing is if I check the PTH and the calcium's low, and I check the vitamin D level and the GFR is normal, so they have a normal GFR and a low vitamin D, that's vitamin D deficiency. So you have to remember that because patients with CKD can also have low vitamin D, low active vitamin D. So it's really important to understand, do they have a low GFR? Because if it's a low GFR, it's likely CKD. If it's a normal GFR in combination with a low vitamin D, then it's likely vitamin D deficiency. All right. Now we come to the patient who has hypoparathyroidism. How do we treat the adenoma? How do we treat the multiple endocrine neoplasia or all the other problems? Oftentimes, it's not that bad. It's really just repleting the thing that we're missing. You're just giving them the calcium. You're not going to do anything with the adenomas, really. You can consider removing them. All right, let's talk about the treatment of hypoparathyroidism. So what are you going to do in this particular scenario? Well, if you accidentally cut the parathyroid out, I can't put it back in, really. So unfortunately, there's nothing I can do about that. In autoimmune diseases, there's not really anything you can do for the autoimmune polyglandular. You can give patients back magnesium if they truly are deficient. And in DiGeorge syndrome, there's not really much you can do either. So oftentimes, it's just dealing with the consequence of hypocalcemia. So just give them back the calcium. And the way that we determine this is by giving them calcium and then giving them something that helps to absorb calcium, like vitamin D. Now, if the calcium is pretty low, like less than 7.5, or they have symptoms such as the tetany, so they have Schaaf-Steck sign, they have potentially the Trousseau syndrome, they have perioral paresthesias, they have even maybe a change in their QT interval, so hypocalcemia, prolonged QT interval, it's actually beneficial to give them IV calcium. You shouldn't delay it and wait for the time of absorption. You should get it right into the bloodstream right away. If the calcium is greater than 7.5 and they don't really have any symptoms, then you have time. Go ahead and give them the oral calcium and the vitamin D, which will help to aid in the absorption of calcium. The other thing I would remember is, again, check the magnesium. If their magnesium is low, give them magnesium, right? The other thing is that when you give patients calcium, they do have a slight risk of developing kidney stones, particularly calcium stones. Calcium phosphate, calcium oxalate, you don't want to restrict the calcium, but again, if you give a lot of calcium, there is that risk. So make sure you monitor for those. In patients who you give calcium, you give vitamin D, they're still not getting better. You check their magnesium, oh, it's deficient. I give them magnesium, but they're still having hypocalcemia. They're still refractory to this. Then you can give them PTH, all right? So you can give them recombinant PTH only in that scenario if they have refractory hypocalcemia and symptoms despite medical management. All right, what about hyperparathyroidism? All right, in this one, you actually could do something depending on if it's primary, tertiary, or even some degree secondary. So let's start with primary and tertiary because these are oftentimes the most severe ones. If a patient has primary or tertiary hyperparathyroidism, you first have to ask yourself the question, is the calcium pretty elevated? So they have hypercalcemia to the point where it's greater than at least 11.5. All right, they do. Do they have bone disease and renal involvement? What do I mean by renal involvement? Do they have CKD? Because that makes this a little bit more complicated because now this patient's going to have hyperphosphatemia and low vitamin D, and they're going to keep trying to trigger PTH production. So do they have that? Also, have they had evidence of hypercalciuria in their urine? And do they also have more frequent episodes of nephrolithiasis? If they have hypercalcemia and at least one of those renal problems, oh man, we got a pretty sick patient now. Add to the list. Do they have bone disease? In other words, do we get a DEXA scan? So remember I told you to get the renal ultrasound? Do they have episodes of nephrolithiasis? You can get a urine calcium, and if that's pretty high, that also increases the risk of nephrolithiasis. And if they have CKD3 or worse, you're increasing the risk of them developing worsening hyperparathyroidism. So in these states, plus hypercalcemia and bone disease, what did my DEXA scan show me? Is it less than negative 2.5, meaning I have osteoporosis? Have I had lots of pathological fractures? This is a sick patient. I need to get on this patient. There's really two big options here I have to ask. Are they a surgical candidate, meaning can I cut out that parathyroid adenoma, or could I cut out that really significant parathyroid hyperplasia? Either way, I got to cut these things out. If they're a surgical candidate and they have hypercalcemia, bone disease, and renal disease, you should just cut them out and get the parathyroid out, do a parathyroidectomy. If they're not a surgical candidate or they don't want to undergo surgery yet, what you can do is you can give them something that will try to suppress PTH production. This is called a cinacalcet, also known as Sensipar. The concept behind cinacalcet is actually pretty interesting. Here's a parathyroid cell. It's the one that's supposed to be making PTH. We call them chief cells. Here we have a calcium receptor. And calcium is supposed to bind to the calcium receptor to tell it to say, hey, there's high calcium, dude. Stop making PTH. Cinacalcet acts like a calcium mimetic, meaning cinacalcet will say, all right, hey, parathyroid cell, calcium out here is pretty high. Stop making PTH, dude. And it'll suppress PTH synthesis and secretion. And then I'll drop my PTH levels. I won't have as much hypercalcemia. I won't continue to damage the bones, and I won't continue to increase the risk of nephrolithiasis. That's pretty helpful. But we do that oftentimes if the patient's not a surgical candidate. The other thing is I don't want the bones to continue to get destroyed. Is there any way I can suppress the PTH that is out there from potentially chewing away the bones? Yeah, I can give them bisphosphonates. And oftentimes that's one of the beneficial things to reduce the risk of progressive bone injury through osteopenia, osteoporosis, and pathological fractures. In the secondary hyperparathyroidism patient, you really just want to focus on treating the underlying cause and preventing them from continuing to produce PTH. So you have to ask yourself the question, is it hyperphosphatemia that's the cause? If it is, give something to bind the phosphate so that they stop binding to calcium. That would be something like sevelamer. This is a phosphate binder which will take all the phosphate that you may have, bind it up, and prevent it from being absorbed so that it stops sticking to the calcium and dropping your calcium levels, and then stimulating the parathyroid gland to make more PTH. Plus, if you bind up the phosphates, that high phosphate won't tell the parathyroid to keep making more PTH. Either way, that'll suppress the PTH levels and allow for less PTH to be produced. The other concept is, do they have hypocalcemia? If they have hypocalcemia, that's the driving factor. That's why they keep telling the parathyroid to make more PTH. Give them calcium. So give them calcium, give them vitamin D, because these things will help to increase the calcium and suppress the PTH production. Now, if they have vitamin D deficiency, even better, give them vitamin D. But CKD oftentimes will respond to phosphate binders, especially if they have hyperphosphatemia, and vitamin D because they're going to have a deficiency in that because of the inability to hydroxylate the one carbon of vitamin D, and then give them calcium because, again, the phosphate will bind the calcium and deplete it, and the decreased vitamin D will deplete the calcium. So give them all three. Vitamin D deficiency, just give them the vitamin D, and they'll naturally increase their calcium. Last scenario, I got a patient with really bad calcium greater than 14. They're developing some bone stones, groans, thrones, arrhythmia prone. Their psychiatric overtones are going crazy. What do I do with these patients? You have to get that serum sodium down pretty quick. And so one of the biggest things here to remember is with severe hypercalcemia, you're basically telling your ADH to not even work on the kidneys and just dump urine. And these patients will become severely volume depleted. So it's best to give them back fluid in the form of IV normal saline. They used to say back in the day to give them normal saline and then give them furosemide, but that's not recommended anymore. It's just best to give them normal saline to replete their massive dehydration. Plus, you have to stop allowing the bones to get chewed up. Don't allow the bones to continue to chew through the calcium. Give them bisphosphonates. And lastly, give them calcitonin, because calcitonin will also suppress the osteoclasts as well. All of these things will help to bring down the calcium level as quickly as possible. If despite all of these medical measures, the patient is still hypercalcemic, you then need to proceed to hemodialysis. All right, my friends, that was a monster lecture on parathyroid disorders. I hope it made sense. I hope that you guys did enjoy it. And as always, until next time.